Good morning. Today we're going to talk about liver transplants. Sorry for all the drama last night about the videos. I guess they're trying something new, but hopefully in some format you got to look at the video. I thought it'd be useful before we do the lecture, and so hopefully you got a chance to look at it. But if you didn't, that's okay. We'll go through the cases and we'll figure out what's going wrong with them. So we're going to talk about normal imaging appearance of liver transplants. We're going to use ultrasound as our imaging modality because a lot of these liver transplants are best evaluated with ultrasound. At least that's the first line evaluation, and then we can move it up to other imaging modalities if need be. And after we go through normal, we're going to talk about the complications for liver transplants. And the good news is that there are actually not that many complications. So if you kind of have an approach to it, then you can look at a liver transplant ultrasound and figure out what's going on with the patient and let them on their way. So let's put this all into some context. When was the first liver transplant done? What do you guys think? Was it done 100 years ago on a human? Was it done 20 years ago? 70 years ago? 60 years ago. I didn't know. I don't know this. Of course I don't know this. How are you supposed to know this? So 1963 at the University of Colorado. They did a whole bunch of transplants, about 4 or 5. None lasted, no patient rather, lasted more than 20 days. And what do you think people died of back then? Infection, actually. Exactly. So it's not, they just didn't have good means to control the infection, good sterile techniques, all sorts of things, but it was infection that these people succumbed to. But in 1967, they had the first successful liver transplant, and I say successful because for them it was one that lasted more than a year, and that's a huge moment, all right? And why did we get so much better at that point? Well, the surgical techniques, even those 4 years had improved. Our immunosuppressive regimens that we used to help these transplant patients had improved. Our anti-infection techniques had also improved, and it was done on a little girl actually, Julia Rodriguez. She's over here, and she had liver cancer. I'm not sure which one, probably hepatoblastoma, some sort of liver tumor, and she did well for about a year until it recurred about a year later and spread to the other parts of her body. But that was a huge moment for liver transplants, and we've come a long way since then. And so these are the basic indications for liver transplant, and there's a few bullet points here, but the idea is that anybody who has a liver that's not working well, it's end stage, these patients are, these patients can get these liver transplants. So it could be for a variety of reasons. In our patient population, we see a lot of patients who are cirrhotics due to alcoholism, but whether it's other diseases like hemochromatosis, primary sclerosing cholangitis, these patients are also eligible for transplants if they have end-stage liver disease. And I put contraindications here not because, again, you need to remember any of these things offhand, but it certainly, it can be obvious that if you have, well, the other thing I didn't actually mention here is hepatocellular carcinoma. You have primary liver tumors, you're also eligible to get liver transplants. But if you have disease that's outside of the liver, you're not going to get a liver transplant, right? So you want to make sure you screen the patient, make sure there's no disease outside the liver. If you have a very big burden of tumor within the liver, then you're not going to get a liver transplant. There's some criteria for that called the Mahan criteria. We're not going to go through those. If you're sick, very sick, if you have a cardiac disease, pulmonary disease, if you can't, if they don't predict that after you get the transplant, your body will be able to cope with the rigors of the post-operative care, that's going to be tough as well. And I kind of put poor social support over here as well, because it's kind of interesting. If you are able to attend our liver transplant conferences at some point, I highly suggest you do so. What ends up happening is that you sit in a room and you have a panel of people who are advocates for the patient to get the transplant, and you have a panel of people who are advocates for the donor. And so they're looking out for the best interest of the donor as well. And there are hepatologists, surgeons, radiologists, psychiatrists, all sorts of things. So they get a very thorough evaluation, and we do a lot for liver transplants in terms of mapping out anatomy for them. But oftentimes, it's the social aspect of what's going on that may prohibit them from getting the transplant. So it's something to at least think about in the back of your mind as a potential contraindication. So we started doing these in the 70s. The one-year survival was 25%. That's dismal. We've gone a lot better since then. So both in deceased and living donor transplant, survival has improved dramatically. 1-year survival up to 90%. 10-year survival, not great, but at 60 and 70%, we're getting there. We're getting to the point where we want to be. And so primary non-function of the graft is the most common cause of graft failure. So for whatever reason, that graft stops working. And we can't really necessarily detect that on ultrasound. That's something that you'd have to biopsy, and there's certain changes in the liver that will indicate that it's just not functioning. But before we go into the complications, let's talk about the anatomy. So we have a bunch of residents here. Some have done ultrasound, some haven't done ultrasound. We'll go through some cases. Don't be afraid, we'll be fine. And let's start with the first case. So I want to know about the normal anatomy for these liver transplants. How many vascular anastomosis do we make? 3. I heard the number 3. Okay, so whoever said 3, tell me about which ones they are. Okay, so you make the IVC anastomosis, right? You make the portal vein anastomosis, and you make a hepatic artery anastomosis. Pretty simple. How about number of non-vascular anastomosis we make?
1.
Ramat said 1. He's very confident. Which one is that?
Bile duct to usually bile duct hepatic duct.
Yeah, so you kind of make an anastomosis for the bile ducts. Great. So this is what a liver transplant looks like. It's a drawing of a liver transplant. Absolutely right. You make 3 vascular anastomosis. That's important to remember. Always take it back to the basics whenever you're confused. And you want to make sure that the hepatic artery of the donor is attached to the hepatic artery of the recipient, that the portal vein of the donor is attached to the portal vein of the recipient, and that you make some sort of anastomosis between the donor's hepatic vein and IVC and the recipient's hepatic vein and IVC. And this is the way we used to do it, is that you take the liver and you have a portion of the super and infrahepatic IVC, and you kind of make a graft between that and the recipient's suprahepatic and infrahepatic IVC. So it's called an interposition graft. But now, of course, our techniques have improved, and this is what you're going to end up seeing a lot of times. It's called a piggyback technique, right? So in this case, you take the liver and you tie off the infrahepatic IVC, and the suprahepatic IVC is joined to the recipient's IVC. So you don't take out any portion of the recipient's IVC. You just kind of attach the donor IVC to the recipient IVC. It has 1 anastomosis instead of 2, and so it takes less time to construct in the OR. Less complications are associated with it. So almost every single transplant you see now will have this sort of surgical technique. And the one non-vascular anastomosis, absolutely right, it's the common bile duct. So you want to attach the donor's common bile duct to the recipient's common bile duct. And if for whatever reason the common bile duct is damaged, particularly in the recipient, maybe they have primary sclerosing cholangitis, something like that, where there's some strictures there, then it's reasonable to do a choledochojejunostomy. So instead of getting the recipient's bile duct up here, you get a loop of bowel. Just a loop of bowel over there, and you can make that anastomosis, and we call it a choledochojejunostomy. And we routinely perform a cholecystectomy in all these patients, so you won't see a gallbladder left in the patients who've gotten a transplant. All right, next person. What's going on here? Oh yeah, you're the bile duct expert. Please, come.
Thank you. So it looks like a ERCP.
I agree.
Provincia.
Okay. So what have we done?
Cannulation of the bile duct.
Okay, and what do you see?
It looks like a stenosis, probably distally as well as some proximal stenosis.
All right, so over here we inject the bile duct. And I don't think we see too much of the bile duct nicely here, but I can understand why you think it maybe is a little bit narrow. But assuming this is okay, I think what you're referring to is this little waist over here, right? It comes across, narrows, and goes big again. And so absolutely, look at this, and I think you need to think of that there's a stenosis. But the one caveat is that oftentimes when these patients get transplants, you're not going to get a perfect match between the donor and the recipient, particularly when it's an adult donor giving their liver to a pediatric recipient, right? So you can have a mismatch at the biliary anastomosis. You can also have a mismatch at the portal vein anastomosis. Those are the 2 areas where you can see these mismatches. And so it looks like there is an abnormal area of narrowing. And so I think it can get really difficult, right? How are you supposed to differentiate this from a stricture? And I think on imaging it gets very difficult. I think you should interpret it the way you do it. Certainly look at the OR report to see if there was any mention that there may be a mismatch. But at the end of the day, if there's worsening ductal dilatation upstream to this, or the LFTs are rising and there's no other explanation then it's not unreasonable for either the, for the ERCP folks to go in and put a stent in here just to open it up a little bit.
Mahan,
Yeah?
are the mismatched ducts or vessels, are they more prone to stricture?
I think so, but I don't know offhand. Ultimately, if you don't have anything that's kind of connecting properly over time, it probably is more prone to strictures, but I'm not entirely sure. And you can have these strictures. In this case, this is between a bile duct and a bile duct. You can have the mismatch. Sometimes you can have strictures between the bile duct and that jejunal loop as well that can develop in that location. So that's something to be aware of. It can also happen in the portal veins. All right, so I need somebody to start going through some waveforms for me. So we'll start off with the hepatic artery. What's the general waveform that you expect to see in the hepatic artery transplant? Good, so the direction is towards the liver. That's perfect. But in terms of let's talk about the resistive index. What sort of resistive indices do you like? What's that? 0.5 to 0.8. That's good. So I like 0.5 to 0.8. Anything below 0.5 is not ideal. Anything above 0.8 is not ideal either. So it's a 0.5 to 0.8 is good. What about velocities? 200. Perfect. 200 velocities, no more than 200. And what about the waveform? Do we have flow in systole and diastole? Yeah, you want flow in systole and diastole. You want flow throughout the liver. You want a sharp systolic upstroke, and you want flow throughout diastole with a resistive index of 0.5 to 0.8. Perfect. Let's talk about the portal vein. Which direction do you want the portal vein to go to? Hepatopetal as well, right? Towards the liver. And if you ever get confused with hepatopetal and hepatofugal, in my reports, I just say the portal vein flows towards the liver. The hepatic veins flow away from the liver. And I borrowed that from Dr. Scout, who's very smart. So I thought that's a very simple way to kind of tell you what direction things are going. And what about the waveforms? Are we going to see this systolic and diastolic kind of appearance of the portal veins? Joe's shaking his head, so he doesn't believe that. So we're going to see kind of a more undulating waveform that's flowing continuously towards the portal vein, towards the liver. We'll show you examples of that. And finally, hepatic vein. What direction do you expect the hepatic veins to go? Fugal, so away from the liver. Right? We don't want hepatic veins going towards the liver. We want it going away from the liver back to the heart. And what about the waveforms of the hepatic vein? Triphasic, right? So there's going to be, that's what they call it. There's going to be all these upstrokes and downstrokes kind of reflecting the right atrial contractions. Very good. This is what a hepatic artery looks like, right? Sharp systolic upstroke, flow throughout diastole, right? If you tell me this is in the kidney, this is what the kidney waveform will also look like. So these organs that need flow continuously throughout the cardiac cycle have this relatively low resistance waveform. Somebody said that up back there as well, I think. And you want a resistive index between 0.5 to 0.8. And peak systolic velocities, as it turns out, can be almost less than 200, and we're okay with that. Now, if you look at a postoperative liver or any sort of liver, and you get an RI kind of 0.8 or a little bit above it, there are a few reasons that can happen. In the immediate postoperative period, you have a lot of edema. When you have this edema, it causes mass effect upon the artery. And when that happens, you can get RIs that are elevated. And so over time, that edema will go away, and the resistive indices will get back to normal. So you can just wait it out a little bit. You don't want to react too much in that first postoperative period. The other patients who get elevated RIs, it's kind of like the kidney transplants. If I'm getting a liver from somebody who already has a damaged liver to start with, then when I get that liver and they start interrogating that RI, it's going to be a little bit elevated. Just like the kidneys and the concept of acute tubular necrosis. If I get a kidney that's already damaged, then the RIs will be relatively elevated with the hope that it goes down over a period of time. This is what the portal vein looks like. Flow above the baseline towards the liver. You may have some sort of undulations, and that kind of reflects partly the cardiac pulsatility, but not in the same way that the hepatic veins will, and partly respiratory phasicity. And as we said, bile ducts you may see, like the bile ducts of the portal vein, you may also see mismatch of the anastomosis, and you got to make sure that you don't necessarily misinterpret that for a portal vein stenosis. Finally, the triphasic waveform, right? You have inflections going above and below the baseline, predominantly below the baseline, and the reason that is, of course, because the hepatic veins flow away from the liver towards the heart. Okay? And so that's the sort of waveform you want to see in the hepatic vein. All right. What's going on here, guys? What do you guys see? transplanted liver. They're all transplanted livers, I promise you. All right. You see this and you see this. What do you think's going on here? Technologist shows you this. It's post-op liver. Seeing a little collection over here. Do you believe them? Gao doesn't believe them. He's looking at it really suspiciously. All right, so what if I show you this image? So this is that, and this is that. All right. Oh, actually up there. So this is basically a pitfall. If you see something like this, and I've had it happen to me, this is why I want to show it to you. Technologists will come in and say there's a little collection over here, and it's a small collection, so it doesn't really matter if it truly is a collection. But again, remember the piggyback technique for the IVC hepatic vein anastomosis. These are just the recipient, the donor IVC and the recipient IVC back to back, kind of cut and cross section, kind of looks like two fluid structures here. If you put color, both will have color. And if you just go from this image to the next image, you'll see that this is the hepatic vein confluence in the IVC here, which is that connecting to the recipient's IVC. So don't be tricked by that. It'll look like that almost always. If you just look for it in your next liver transplant, whoever's on ultrasound today, this is kind of annotated for you, the donor IVC, recipient IVC, that's the anastomosis, and that's what it'll kind of look like on when you on a transverse view. All right, so this is the summary of what's normal. It's important to know what normal is before we go into the complications. Again, hepatic artery, sharp systolic upstroke, good flow in diastole, peak systolic velocities less than 200, RIs between 0.5 to 0.8, ideally 0.6, 0.7. Main portal vein monophasic flow towards the liver, some degree of undulation. This one doesn't have too much, but it can go a little bit up and down like that due to respiratory variation and some cardiac contractility that's transmitted through the liver to the portal vein. The hepatic vein, vastly different, right? Triphasic waveform reflecting the right atrial contractions. And remember about the IVC anastomosis and what that can look like. So as we go through complications, I just want you to have this as a framework so you can kind of approach these cases. The easiest way I think to do it is to look for complications that are vascular in etiology and those that are non-vascular in etiology. And the non-vascular ones are kind of like probably my favorite because those are easy to kind of detect. Right? We're talking about collections. They can be inside the liver. They can be outside the liver. And we're talking about masses. That's pretty much it. All right. Vascular stuff, we're talking about our anastomoses that we have. The hepatic artery, the portal vein, the hepatic vein, and all three of them can get narrowed, right, or stenosed, or they can be completely obliterated with thrombosis. So that's it. You're just looking for those two things on those anastomoses. And then there's post-biopsy complications kind of put into the vascular category. Those are arteriovenous fistulas and pseudoaneurysms, and we'll have some cases and we'll figure out how to diagnose those. All right, next case. What's going on here, guys? Transplanted liver. Coming to the ER. You're on night float. Jamal's not there. You're on your own.
Like a well-circumscribed hypoechoic focus that has some linear echogenic regions within it.
Perfect. Love that description. So there's this mass over here, essentially, or hypoechoic focus is probably a more accurate way to describe it. It looks pretty heterogeneous. You don't really like it. There's this echogenic stuff in here. So what do you think that represents, the echogenic stuff?
It could be air.
All right. Why do you think it's air and not, say, calcifications?
So you have sort of a reverberation on it.
I love it. Perfect. That's exactly how to take it. There's no shadowing if there was a calcification. So you got a really heterogeneous area with some air in it. What are you worried about?
Abscess.
Perfect. So you got a CT scan, and there you go. This is a hepatic abscess over here, right? There's another one lower down, but I didn't have any air, so I don't want to show you that. But this one's a hepatic abscess. These are the foci of air within it. These are the foci of air within it, and that's a hepatic abscess. What about this one? That's the liver. That's the duodenum. What do you think about this? Is it normal or abnormal?
It's abnormal. It looks like heterogeneous collection
Yeah.
next to the, like between the liver and the duodenum.
Absolutely. And all
It
these.
depends how long post-op it is.
I'm not too sure, but what are your things you're thinking about?
I mean, it can be collection or hematoma.
Yeah, it could be a hematoma. And what else? Anything else you want to put in that differential? If you don't want to, you don't have to put anything else. It's up to you.
I mean, it can be just a leak.
Okay,
Yeah.
good. And that's a hematoma. There's another hematoma here, just to know that it can be subtle. That's the liver, and that's the kidney. In Morrison's patch, we have a little hematoma here, a little bit more echogenic. And there's nothing about this that tells me it's a hematoma. All right, but you think common things being common, post-op, probably going to be a hematoma. And so that's kind of the point of this case, is that the first complication that you can anticipate and you should look for is collections. They can be in the liver, they can be outside the liver. And when you're dealing with collections in liver transplants, you're kind of dealing with these things. You're dealing with hematomas, you're dealing with abscesses. Loculated ascites, like over here, can kind of look like it's a collection. Or a biloma. So you alluded to, I think, bileak as well when you were talking about bilomas. And it turns out that most of these things will look pretty similar on ultrasound. Right? There's no way we can tell the contents of something on ultrasound. Anyone who asks us to do so, that's ridiculous. We can't do that. But what's ultrasound useful for? Ultrasound is useful for following these collections. Are they getting bigger? Are they getting smaller? Right? We want them to get smaller. And ultrasound is also very useful as a modality that will guide our drainage of these procedures. Right? If we can see it on ultrasound, we can probably get a needle in it and drain it out, and that's how we're going to figure out what's going on with it. Okay, so there are some signs that Cheyenne saw, for example, when he saw air in that collection that tells us, yeah, this looks like it's an abscess, an infected collection. But beyond that, it becomes very difficult. And what we end up doing is playing the odds like you did, saying, look, it's a post-op patient. I see a collection there. It's probably going to be a hematoma. You know, we can follow it and see what happens. So this is another abscess over here, right? Another heterogeneous collection, foci of air within it. And that kind of looks like an abscess. And the thing with abscesses, and we'll get to it in one of our cases, is whenever you see a liver abscess in a transplanted patient, make sure you interrogate the vessels. Okay, there can be reasons for hepatic abscess. Maybe it's a hematogenous source. Maybe there's an infection elsewhere like diverticulitis and it's going to the liver. That's fine. But the worst thing you'd want to miss is damage to the hepatic artery. And particularly with the hepatic artery, you can get these abscesses, whether it's stenosis or thrombosis. So whenever you see that, like you did, you know, you took the case, in the real life, now you want to look at the hepatic artery and make sure that that's open, because if, and we'll talk about the hepatic artery, damage to that can damage the bile ducts, which can lead to bile leaks, which can lead to abscesses. Perfect. All right, next case, what do you guys think is going on over here? You get the image of the porta hepatis, that's the portal vein. Ignore this little thing over here. What else is going on? Davram, what do you think? This is normal liver. That's a transplanted liver here. That's the portal vein. What do you see in between those two?
Looks like there's a collection.
Yeah, it looks like there's a hypoechoic thing there. You're not really sure if it's a collection per se, but it could be a collection, absolutely. It looks a little bit more solid than you'd expect a collection, perhaps, but it could be like an organized hematoma, right? So you see that, and has no flow in it, at least not that we detect. So we say, fine, I'm not really sure what it is. It's been going on for a few days. Let me get a CAT scan. So what do you see over here?
Yeah, so there's a hypodense area in the liver.
Okay.
The caudate lobe.
Yeah, it looks pretty, I'm not sure if it's in the liver or perhaps this is the caudate lobe and it's in the porta hepatis. It looks pretty infiltrative, right? I mean,
Right.
you can't really define the borders. And again, you know, on this and this, it could be a really, you know, collection of a lot of material that's very tenacious and difficult to kind of move around. But alternatively, it could be kind of a very infiltrative solid collection. And it's been there for a while, a solid mass, and it's been there for a while. It's not going away. So what are we worried about in this case?
One of the concerns in transplant patients is PTLD.
Oh, what does that stand for?
Post-transplant lymphoproliferative disease.
Perfect. And what do you know about it? How do these patients get it?
They're immunocompromised,
Mhm.
so they're prone to it's Epstein-Barr virus.
Perfect. So they can reactivate because they're immunocompromised. So the body can't deal with the Epstein-Barr virus, and it results in proliferation of B cells. And you get this lymphoproliferative disorder. And does PET-CT help in that?
Yeah, probably.
Well, it probably does. This is why I asked you the case. So here we go. This is the PET-CT, and there's uptake over here. So this was PTLD, and the thing with PTLD is it's something that you worry about in transplant patients, and for practical purposes, anything that lymphoma can do, in terms of its imaging appearance, PTLD can do. Right? So adenopathy, single hepatic mass, multiple hepatic masses, infiltrative mass of the porta hepatis like this one can do that. You get them in renal transplants as well. And so ultimately, you're not going to know this is PTLD. I mean, if you have a PET CT, that's going to be much more obvious. That's probably what it's going to be. But it's got to be somewhere in the back of your mind. You can't forget about that. Okay? Now, it can happen. It happens in only a minority of liver transplants, but it can happen as early as 1 month, as late as 7 years. Right? So it's not like this is too early for PTLD or it's just too late for PTLD. You can get it. So always think about it. The only thing is if they present after a year, generally they do poorer. Dave talked about why these patients end up getting PTLD. And one of the things is, when you look at this and you're worried about PTLD, you still have to biopsy it because there's different stages. There's a stage where you just have proliferation of B cells. In that stage, you want to increase your immunosuppression. And sometimes they do okay. And there is a stage where it transforms from PTLD to frank malignant lymphoma. Those patients need chemotherapy. So for your purposes, when you see something like this, you can suggest it. And next step is to get biopsy. And if it's just PTLD, and if you adjust the immunosuppression, decrease immunosuppression, then these patients could do better.
So it's just B cell proliferation you want to decrease.
Exactly. But if it's frank lymphoma, you have to give chemotherapy. That's why the biopsy is very important. And I don't know, in fact, the histological changes that determine whether immunosuppression adjustment is appropriate or treatment is appropriate. But the point is that there is a spectrum, and that can only be kind of figured out by biopsy. So you don't always have to give these patients chemo. And that's kind of it from my perspective for non-vascular complications that I look at. I look for collections, I look for masses, and that's about it. And then I go to the vascular complications. So here we go. The fun stuff. What do you think is going on here, guys? So we have the right hepatic artery, the left hepatic artery, and the proper middle hepatic artery. What's wrong with this waveform in, say, the left hepatic artery? Tardus parvis. Those are the two of my favorite words in ultrasound. I love saying them. Tardus parvis, right? So what does tardus parvis mean? Yeah. So the time to get to that peak systolic velocity is delayed. That's what we're talking about. And what about the peak systolic velocity itself? It's dampened. It's relatively dampened. And so what you end up getting a lot of times as a result of that, as a side in these tardus parvis waveforms, you end up getting resistive indices that are lower as well. That's 0.3. So I've interrogated my right hepatic artery, or the patient's right hepatic artery, the left hepatic artery, tardus parvis waveform. So what does that tell me? Oh, Stephen knows this. What's going on? There's a stenosis. Now, where's that stenosis? Good. So it's not going to be in the right or left, but it's going to be kind of more proximal to that area. That's what you're kind of getting at. So I interrogate that area as well, and yeah, it doesn't look as bad, but it's still tardus parvis. I mean, I like systolic upstrokes like that, And so when I interrogate the proper middle, the main hepatic artery, that's still tardus parvis. So that shows me that the area of stenosis may be even more proximal to that. The problem is that I can't interrogate that region because there's too much bowel gas. Right, but all I can say by these images is that there is a tardus parvis waveform, there is a stenosis somewhere, and it's probably before even the intrahepatic portion of the proper hepatic artery, and I can't visualize it. So, what do you want to get? Do you want to any other imaging study you want to get?
Could get CT with contrast.
Perfect, CT with contrast. So we got a CT with contrast. We got a CTA, in fact. It's a CT with contrast at early arterial timing. And we reconstructed those images to make it look nice and pretty. And this is the celiac artery. That's the splenic artery. That's the GDA coming off. That's the proper hepatic artery. And what do you see here? Or what don't you see here? Exactly. You don't see the hepatic artery really nicely across this area. And, it's probably completely stenosed. There's post-stenotic dilatation. And so the areas we were interrogating the liver were like here, and maybe a little bit over here, and here. But we couldn't get to that portion over here. So that's where the stenosis was. So we brought them to our IR colleagues. Beautiful correlation. See how tight that stenosis is? They put a balloon in there, expanded that out. This patient did great, and she's still alive, and she gets her transplants. You'll see her at sometimes in our reading room. And so this, present to our reading room. So this is hepatic artery stenosis, all right? So the teaching points are recognize this tardus parvis waveform. We all seem to recognize it over here, so that's great. Slow systolic upstroke, diminished amplitude of the hepatic artery. That tells us there's a stenosis proximal. And if I can't visualize it, I want to get an angiogram, whether it's a CT or an IR angiogram. And if I can, if I do actually work backwards from the hepatic arteries and I find an area where there's focal elevation of velocities to above 200, then on ultrasound I can say that's where the stenosis is. But if I don't see that stenosis, I want to get an angiogram. And again, this is what normal looks like, and you can see how abnormal this waveform looks compared to this normal one. This is another case kind of with the same teaching points. You get a transplanted liver, you look in this location where you expect the proper hepatic artery to be, you see a tardus parvus waveform, and so you know that the stenosis is going to be somewhere over here. But we can't visualize that area because there's too much attenuation of the sound beam by bowel gas. So we get an angiogram, and again, nicely you see the stenosis. And a lot of times the stenosis ends up happening at the anastomosis, which is at a location that may be too difficult for us to see on ultrasound. And that needs to be opened up. So again, this is a great article. Whenever I give these talks, I always I go through this article myself, and I suggest all of you go through it at least once a year. Liver Doppler made simple. They talk about objective evidence and subjective evidence of tardus parvus waveforms. It's a terrific article that kind of explains all of this stuff if you ever get confused. All right, so again, this is the tardus parvus waveform. I'm kind of emphasizing this because it is an important point, and you can use these principles for renal transplants and indeed for almost any organ that you interrogate. So if you know this principle, you can apply it to anything. Okay, great. So let's go through case 9 now. What's going on over here? So we're interrogating the porta hepatis. We see a really nice flow in the main portal vein, right? It's going towards the liver. Good flow over here. What aren't we seeing in the porta hepatis that we should see right next to it? I kind of heard the right answer, but I'm not sure. Hepatic artery. I think Tom said hepatic artery. And so I don't see the hepatic artery, and so we try really, really hard, and we weren't able to find the hepatic artery, so this is a post-op patient. What are you worried about? What's that? Thrombus. And what else do you see on this image in terms of the grayscale appearance? That's the liver.
That kind of dark, hypoechoic.
Right there, right?
Yeah.
So that doesn't look too good either. So very good. So this is what this person is, a pediatric patient actually. And this is what his liver looked like. Lots. What do you think these things are? Areas of low attenuation, non-enhancement. What's that?
I mean, is that just further from the thrombus? It's just not being perfused?
It's just not being perfused, exactly. So these are areas of ischemia, infarcts in the liver, and it's hard to show this. This is the main portal vein over here, but if you follow this, the celiac artery coming off, there's actually no hepatic artery that we could detect. So this is hepatic artery thrombosis, and that's a devastating complication. All right. You want to tell us a little bit why it's a really worrisome complication?
Well, what was so I mean, even though it's the only blood supply to the bile ducts usually.
Perfect. That's what I wanted to hear. So the hepatic artery is the sole blood supply to the biliary tree. So if the hepatic artery is compromised, your bile ducts aren't going to work too well. They start to stricture, they start to dilate over a period of time, they can have bile leaks, you can have abscesses. And so when, Cheyenne took that case earlier and saw an abscess, that's why you got to worry about the hepatic artery because, yeah, that could be another hematogenous source, but it could also be the hepatic artery. So whether it's stenosed or thrombosed, it can give rise to biliary problems. This is another case of hepatic artery thrombosis. You see the main portal vein, don't see anything in the porta hepatis, an area of heterogeneity in the liver, just like the case Tom just took. Multiple infarcts, no hepatic artery detected on this one. And so this turns out to be the most clinically significant complication in liver transplants, and something you're all going to come across, particularly night float when they do those transplants, and they come and it's fresh post-op transplants. As the technologist interrogates the main portal vein, gets flow, sees the hepatic veins, gets flow, looks for the hepatic artery, and can't find hepatic artery flow anywhere. And this is a fresh transplant. And that's really worrisome, because if you're calling hepatic artery thrombosis, they have to go back to the OR, and they got to fix that. So that's a huge thing. You don't want the patient to go back to the OR if they don't have to. So they're relying on you. So what can end up happening is, particularly in that fresh post-operative period, there may be a lot of edema. There may be a lot of gas around that area, and so you don't actually visualize things well. So one thing that people will ask you to do over here, and it's not uncommonly done, is that you re-image after giving a vasodilator agent. And they do it up on the floor. It's called nifedipine. And so this is just an example of that. This is not a thrombosis case, but this is a case where you see flow in the hepatic artery and no diastolic flow. So that's kind of worrisome. And when they give the vasodilator, 30 minutes later, you can see good diastolic flows. So this tells us that, you know what? The hepatic arteries are present. They're open. What we're seeing now may be related to edema. So let's just wait it out a little bit and follow it. So that's something that they may ask you to do, and that's not unreasonable. However, despite giving nifedipine, if you don't see any hepatic arteries, you know, they'll ask for an angiogram maybe, or they may take them back to the OR. And so this patient, for example, this pediatric patient, yeah, they didn't see the hepatic artery. You bet they gave nifedipine before they decided to take him back to the OR and fix that problem. And so as Tom said, it's critical to recognize this because it's the sole vascular supply to the biliary system. You can get biliary necrosis, you can get abscess formation, the hepatic artery is compromised for too long, and the mortality rates go up to 55%. That's a huge mortality rate. So you need to make sure you recognize this. It's one of the most important things we can do for these transplant patients. All right, what about this case? This case kind of puts a few concepts together. What's going on over here? It's a CAT scan, that's an ultrasound of the same thing. So what do you see in the left hepatic lobe?
Multiple hypodense masses.
Yeah, it looks like multiple hypodense masses, and you, go ahead.
They look cystic on ultrasound.
Yeah, and this guy comes in with fevers and leukocytosis, so
So you can have multiple abscesses.
yeah, I think that's very reasonable. It's a transplanted patient, looks like, you know, smells like multiple abscesses, and so what are you worried about?
Like biliary ischemia.
Yeah, exactly. So then we get an ultrasound, and we evaluate the hepatic artery, and what do you think we see over here? So we're interrogating the hepatic artery, and we're kind of seeing a waveform that goes from here to here like that. Our eyes on the lower side. This is another area of the hepatic artery. So how would you kind of qualify this waveform, if you have to? This one here.
Low peak systolic velocity. It could be like almost looks like a collateral vessel, maybe.
Okay, that's a possibility. Okay. Anything else? So it kind of looks like a, okay.
It's TARDIS. I mean, I guess kind of.
Yeah, so I mean, you look, so the person who interpreted this anyways thought this was kind of a TARDIS parvis-y waveform, thought there was hepatic artery stenosis. You think it's maybe a collateral vessel. And so that's not unreasonable to think. And so regardless, there's something abnormal with this. You know, you don't like these hepatic arteries. These are not the normal hepatic arteries that we would look at. So what do you want to do next?
Search more proximal.
Search more proximal. We can't look at more proximal than this.
How you get a CT.
Get a CT. So this is a CT. What do you see here? This is a CTA. That's the aorta. That's the celiac artery. That's the splenic artery. What do you expect to come out right over here?
The common hepatic.
Do you see anything?
No.
No. So what do you think?
It's thrombus.
Completely thrombosed. And here you see the abscesses as well. Then they went to IR. What do you see here? Same thing?
Yes.
Celiac artery cannulated, splenic artery here. You can't get any flow in the common hepatic artery. So that's a great case. A lot of people take this case, and you nailed it. So a lot of people take this case, and they say it's hepatic artery stenosis, but then they get confused because I'm not seeing any hepatic artery, right? Because it's completely thrombosed. So why am I seeing hepatic arterial flow over here when I don't? My whole hepatic artery is thrombosed. And the reason is that if it happens over a period of time, the body is a remarkable thing that it can have all these collaterals that develop and can supply the liver. And so one pitfall to be aware of is that even if you sometimes see this kind of a TARDIS parvis waveform in the liver, that there may be indeed an underlying hepatic artery thrombosis, and that these vessels, as Kyle suggested, were just collateral vessels that have been recruited. Regardless, that's not going to change what you need to do for the patient, which is a CTA and an IR treatment. But that's just something to think of in the back of the mind. And so this, as you can see, was completely thrombosed over here. This was, I think, a month ago or this was the actual portal venous phase. You can see how nice you see it on the CT. On the portal venous phase, it's actually this vessel that's thrombosed. That's the hepatic artery. And you can see how it's completely thrombosed over here. And this is what it was a month ago. So it was open. And this is the angiogram that they did. So this is the occluded hepatic artery. When they injected the SMA, they found that there was a little bit of collateral flow that supplied the liver through the SMA. In fact, it was these vessels that were being interrogated that had those abnormal waveforms. So collateral arteries may also have kind of a more TARDIS parvis appearance. Great. How about this case? We're interrogating the main portal vein. We see a little bit of flow, but is that reassuring for us, or is there something else going on here? So the main portal vein comes from here to here. We have an arrow. And what do you see? No flow, exactly. Well, we see flow towards the periphery of it, but the majority of it has no color flow. Looks like there's all these low-level echoes in it. So what do you think is going on? Yeah, it's partially thrombosed. I would say it's nearly completely thrombosed, but there is a portion that's open, so you wouldn't be incorrect in saying that. And so this is pretty, relatively straightforward. The hepatic arteries are the ones that you really want to be worried about and can be tricky, but the portal vein, again, can either be thrombosed or stenosed, and this is what portal vein thrombosis looks like. We've all seen it in the ultrasound service, whether it's in a transplanted liver or a non-transplanted liver. It looks the same, filled with low-level echoes, confirmed on a CT scan. And the only teaching point I'll make here, and I'm sure you've heard of this, is that sometimes clot may be very hypoechoic or in fact anechoic. So it looks like there's fluid in there. So it looks like, on grayscale imaging at least, that portal vein is open. But you always want to confirm on color imaging and spectral waveform, because sometimes clot in its acute forms can look that way, and you shouldn't allow that that shouldn't just be reassuring that there's no clot inside of it. You need to do color and spectral Doppler imaging as was done over here. What about this case? So here we're interrogating the portal vein. I'm getting velocity of, about 40 in this location, and 230 just a little bit more distally. So what is that? And look at the waveforms are also going from, well, it goes from about 40 to about 200 over here. What do you think is going on over here?
There's a stenosis between those two sample portions.
Absolutely. Absolutely. So it looks like there's a stenosis because there's this jump in velocities. Now, we don't really have a good idea of what that jump should be in terms of a ratio or a good velocity. People have looked at this, and it's difficult to know. Luckily, portal vein stenosis is not a common complication. But inherently, when you look at something like this, that's a huge discrepancy, So we got an MRI, and you can see this is the portal vein over here. This is the portal vein over here. And what do you see around it?
It's like soft tissue density.
Yeah, I don't know what it is either. I mean, it looks like there's some adenopathy or soft tissue. It looks like, this is a T2 weighted image. It's kind of has this bad T2 signal here. It's enhancing. This actually, I thought for my money's worth there's going to be PTLD or something, but this actually resolved. Maybe it was PTLD and they decreased immunosuppression, but they didn't biopsy this, they didn't do anything about this, and actually got better. But this just goes to show that this is the reason you had portal vein stenosis, because you had adenopathy kind of pushing upon it over there. And so the key finding here is really this elevation of velocity with some kind of abnormal aliasing and weird, turbulent waveforms in that region of stenosis. And so this is kind of what's been put out there in the literature in terms of objective evidence of portal vein stenosis, an absolute portal vein velocity of greater than 125. Well, certainly this one meets criteria at 230. A ratio of 3 to 1 increase. This one also meets that ratio criteria. And of course, we alluded to this at the beginning of the lecture, that if you have a mismatch at the anastomosis, that can also kind of make it look like there's a jump in velocities. And so oftentimes when I see this, I do say that, listen, there is this jump, and it may be stenosis, but it could also be due to a mismatch. And again, as long as the liver is working okay, no one does anything about it. Well, again, we don't see this that often, so I wouldn't worry too much about it. I'd worry more about the hepatic artery thrombosis and stenosis. Know those two things very well. And this is just another case showing the same findings. An area of narrowing, velocity to jump from 30 to 170. Portal vein stenosis over here. What about this one? Maybe a little bit difficult to see, but I'll help you out. We're interrogating the right hepatic vein over here with grayscale and color imaging. All right, so what do you see in the right hepatic vein? Yeah, I agree. So some of this flow is coming towards. I'm not sure what this is all about. What else do you see there? Is it filling in completely?
No, it's not filling in completely.
Yeah, there's some gunk in there, and it's not filling in completely. So what are you worried about?
Well, the two things, it's not filling in something from both.
Yeah.
Yeah.
Yeah. Then that's as far as you can take it. So we got a CT scan, and this is really hard. I really tried to find some good ones from here, but we don't see this complication that often, which is a good thing. That's one of the hepatic veins. That's another hepatic vein. That's the left. That's the middle. They look like they have contrast. What about this one, the right one? And this is better seen on the coronals over here as well. So this is right hepatic vein thrombosis. All right. We've covered the hepatic arteries. We've covered portal vein thrombosis and stenosis. We're getting to the hepatic veins now. This is hepatic vein thrombosis. The same principles as the portal vein. Don't just look at the hepatic vein and say, oh, it's good on grayscale imaging. Interrogate it. Make with color and spectral imaging. Make sure that it's patent. And again, it's an uncommon complication, but we'll come across it from time to time. This is another nice case of a thrombus here at the junction of the hepatic veins in IVC, going into the IVC, nicely seen on the CAT scan as well. So hepatic vein thrombosis in this patient. I don't have a case of hepatic vein stenosis. I searched really hard in Montage. There's like 3, but they weren't really good images, so I don't have a good case of that. Nor is there a good criteria in the literature. But again, if you see a focal elevation in velocities, more than 3 to 1, I think it's very reasonable to at least suggest that there may be a stenosis over there. All right, we're getting to our final couple of cases. What do you think is going on over here? So a couple of images. I'll kind of go through the case with you. We're interrogating the left hepatic lobe over here. And what do you guys think?
I see turbulent flow.
Right here?
Yeah.
Absolutely. Area turbulent flow, when we interrogate it, there's like velocities like 250. So that's turbulent flow.
And then in the sample artery,
Yep.
seeing looks like a TARDIS parvis waveform.
Okay. I like that.
The velocity is kind of low, but it's essentially very high diastolic flow.
Perfect. And what do we see in the portal vein?
I'm trying to see if that's pulsatility or.
Absolutely. You're not used to. Remember, the portal vein is supposed to just be like really kind of undulating like that without these sharp upstrokes. And the whole portal vein is littered with sharp upstrokes here. So you've made all the findings. What do you think is going on?
So there's probably, did this person have a biopsy? Right.
Absolutely.
So it's a fistulous connection between the arterial and portal system.
Perfect. Hepatic artery to portal vein, arteriovenous fistula. And these can be kind of the toughest cases to detect because they can be very small and sometimes inconsequential. And it can also be tough because you have to look at a constellation of findings to kind of put it together, and you did it perfectly. So this is hepatic artery to portal venous fistula. In these transplant patients, this happens after biopsy. This patient's liver wasn't doing too well. They biopsied that area, and they probably created an iatrogenic fistula. And so the idea over here is that when you look at these vessels, there's this arteriovenous fistula. There's 3 components to it. Right? You have the fistula itself, which is the connection between the artery and the vein. And as Marcus said, that has really turbulent flow because you have all this really high flow from the artery going into this fistula and draining by the vein. So that area is really high flow. Looks like, all these areas of turbulent flow over here. Sometimes you can get a soft tissue bruit because the parenchyma around that area kind of vibrates because there's so much flow going through that area. It's much like an arteriovenous fistula, in the arm. If you ever feel those, you can actually feel the vibrations from that fistula. So here you see the turbulent flow. Now, the hepatic artery that's feeding the fistula, in the hepatic artery, normally you get relatively low resistance flow, right? So you have an RI of 0.5 to 0.8. But in these fistulas, that low resistance flow even gets lower, all right, because it's going into the venous system, which is a low resistance system. And so what that means from a practical perspective is that your resistive indices are going to go down. Okay, it means you're now dealing with the resistive indices of less than 0.5. If you were to take this resistive index of this over this divided by this, it would be 0.2 probably. It's really not a lot. So it shows that there is very, very low resistance flow in the hepatic artery. And now this portal vein, which generally is not used to getting any direct arterial flow, is getting so much arterial flow that it demonstrates all these sharp peaks, which are all telling us that there's pulsatility here. So it's kind of feeling the pulsatility of that hepatic artery. So if you can put that together, that implies it's an hepatic, arterial venous fistula essentially. That's exactly what this says over here. I think this will be our last case. So this is an interesting patient who had a liver transplant for a primary sclerosing cholangitis, had a repeat biliary issues within the transplanted liver. Had to put an external to internal biliary catheter in order to treat that stricture that developed. And through that external to internal biliary catheter, there was hemobilia. There was blood coming out of it. So they got worried. So we have an ultrasound here. What do you guys see? So it's a grayscale image. This is the transplanted liver. I can't really define maybe the inferior border of it, but imagine this is kind of IVs at the porta hepatis or within the transplanted liver. What do you see here? Does it look like a solid or cystic mass? Cystic mass, right? And we know it's cystic because there's like no echoes in it. It's like increased through transmission, pretty thin walls. Looks like a pretty cystic mass. So hepatic cyst. Are we happy? Tom's not happy, but I'm not sure if everyone else is happy. What's that? Sure. What do you think? Now is it a cyst? Cysts don't have color, right? Cysts don't have any flow in them. So what do you think is going on here? What does this kind of look like to you? And what does that mean? Perfect. Looks like a pseudoaneurysm. So that's exactly what this is. And this is essentially showing you that if you see a cyst, just like you see, the portal vein may have, appear normal on grayscale imaging, always put color, always put spectral. This is a pseudoaneurysm that was caused probably by that placage of that external to internal biliary catheter in this patient and had hemobilia. And so on color imaging, you see this yin-yang pattern of flow going inside the pseudoaneurysm and the flow escaping the pseudoaneurysm. So you have flow going both towards and away from the transducer. And if we were to find the neck, we could see the spectral waveform, which I'll show you in another case, going both towards and away from the transducer. And there's a bunch of treatments you can do. And this patient went to IR because they needed to treat this, and they injected the superior mesenteric artery. In fact, they injected the celiac artery, couldn't get any flow, so his hepatic artery was completely thrombosed. So they injected the superior mesenteric artery, and they saw all these really weird collaterals over here as a result of that thrombosis. And they couldn't kind of navigate through these collaterals, as you can imagine, to coil this. And so they actually had to go from outside with an ultrasound, use a needle, and put glue to kind of embolize this area, which they did. So it's kind of an interesting case that way. This is another case of hepatic artery pseudoaneurysm. Within the liver, again, flow going towards the liver and away from the liver. And when you interrogate these regions, flow is going towards the liver and away from the liver. Number 2 is towards, number 1 is away. This is what it looks like on CT scans. Again, there's a bunch of treatments. You do want to treat these because they can burst and cause hemorrhage everywhere. And so now we've basically gone through all the complications. There's not much more you'll see that doesn't kind of fit into one of these categories. And so if you're able to understand the general concepts of why things look a certain way when they're complicated, then I think you'll be fine. And this is essentially the summary of all the vascular complications I want you to remember. Focus on the hepatic artery. Recognize hepatic artery stenosis with the tardus parvus waveforms. Recognize hepatic artery thrombosis, where you don't see any hepatic arterial flow, and that sometimes you may be asked to give a vasodilator in order to detect these vessels. Recognize the appearance of pseudoaneurysms and arteriovenous fistulas. This, I think, the latter can be challenging. At least I found it challenging as a resident. So can go through the 3 criteria that you need in order to recognize an arteriovenous fistula, and you'll be fine. Fluid collections, remember the imaging appearance is often non-specific. If you see air, we're worried about abscess. Other than that, it could be any number of things, most likely going to be hematomas. And we just use ultrasound to follow them and hopefully use it as a modality in order to drain them if needed. And remember, tumors, PTLD is something to think at the back of your mind. It can happen at any time. And it's something that can look like lymphoma. So single mass, multiple masses, infiltrative mass, adenopathy everywhere. Think of PTLD in transplant patients.